Hello, my name is Dr. Allison Nguyen, and I'm a clinical pharmacist at the Children's Hospital of Orange County Specialty Pharmacy here in California. I wanted to thank you all for coming to listen to our poster presentation about assessing the value of pharmacist interventions through cost avoidance estimation in an integrated pediatric health system specialty pharmacy setting. Of note, I have nothing to disclose. To start, there are studies that have been done that have attempted to categorize and analyze the types of clinical interventions and the effects on the patients and the health systems by collating financial data from payers to estimate costs of certain outcomes. For example, pharmacist interventions relating to outcomes of adverse drug events, or ADEs, have been attempted to be quantified using evaluation methods such as the NASP method, Naranjo scale, and the common terminology criteria for adverse events, or more easily said, the CTCAE, to come to a cost avoidance quantification. The NASP method creates a probability scale of an ADE happening in the absence of a pharmacist intervention, using the scale of 0, very low, low, medium, and a high likelihood of an ADE in the absence of an intervention. The Naranjo scale, also called the Adverse Drug Reaction Probability Scale, was developed to standardize the assessment of causality for adverse drug reactions. And the CTCAE is a list of standardized definitions for adverse events published by the National Institutes of Health. These pharmacoeconomic analyses are often done in the adult population, where there's more information about the kinds of interventions done and ultimately the clinical and economic impacts of these interventions. We wanted to do this study in order to look into the interventions made in our health system specialty pharmacy, or HSSP, in pediatrics, seeing as there's a lot less studies that have that information readily available, to see if we can qualify our pharmacists' clinical interventions and report the cost avoidance associated with specialty medications in our pediatric ambulatory clinics. Secondarily, we wanted to examine the severity classifications of these interventions, the prevention of ADEs, and to look at the time spent by the pharmacists on it. This was a single-center retrospective cohort study examining interventions documented by pharmacists for CHOC patients using our therapy management software system, Theragy STM, with integrated tools for data collection and specifically for clinical intervention documentation. Patients were included if they were followed by our specialty provider clinics here at CHOC for cystic fibrosis, inflammatory bowel diseases, rheumatoid or inflammatory conditions, or growth hormone disorders, and opted into clinical services by our specialty pharmacy between January 1st and December 31st of 2023. Patients were excluded if they were not being followed by specialty providers by CHOC for the above disease states during this time period. Chart review is conducted to collect demographic data, therapeutic category, and details on the clinical interventions, such as the involved medications, affected parties, and the outcomes, as well as the time that was spent by the pharmacist as well. The interventions that were included were those that had systematically assigned cost avoidance impacts based on current literature. And this included interventions related to drug-drug interactions, or drugs that were not indicated, or suboptimal drugs, dose, route, or administrations, ADEs, or those related to drug allergy prevention and management. The CTCAE was used to determine the severity should one occur, and the average health charges used for the estimation of costs were reported from the Pediatric Health Information System from the 2022 fiscal year and used to determine this cost avoidance. So, with the results in our study, there was a total of 180 patients that had interventions that would qualify, with the percentage breakdown shown to you here on the chart, and the most patients being serviced were 49.4% of patients being serviced for their growth hormone disorders. The average age was 11.5 years, and 46% of these patients were male. So within these 180 patients, a total of 312 interventions were conducted, and 149 were able to be assigned a cost avoidance based on the established models as mentioned previously. An estimated total of $473,292.35 was quantified as a cost avoidance during this time frame. Medication monitoring made up 47.3% of this, and ADE prevention and management made up 29.7%, both being the largest contributors to these potential cost avoidances. The largest category of interventions were categorized as medium/preventive clinic visits, which was 55%. As you can see in our practice, the largest category of interventions and their cost avoidance came from the growth hormone disorders, with an estimated $408,687.64 of avoided costs, followed by cystic fibrosis, which had $32,234.27. There were a large number of clinical activities and interventions that were unable to be assigned an associated cost avoidance, with the largest proportion being that of the coordination of care, which includes things such as lab reminders or appointment reminders, shortage mitigation, coordination, and communication between patients, providers, and other clinics and affected parties. So some limitations that we ran across was that there was no average cost of a clinic visit that was available within the 2022 data. So that information was extrapolated from a study based off of Young et al., based off of the rate of inflation. So it does remain a rough estimate. Also, it is very important to highlight the subjective nature of assessing the impact/severity of an intervention. So we did our best to mitigate that as much as possible by having 2 independent reviewers evaluate the intervention once the pharmacist who conducted the intervention provided rationale and the relevant information to the case. So another important thing to keep in mind is that these cost avoidances do vary by specific institutions and specialty pharmacies, because the variation from the HHSPs can happen due to differences in protocols, how different clinics and specialty pharmacies have procedures, different areas of practice, as well as specific challenges that were present at the time, such as shortages, recalls, natural disasters, etc. Okay, so in conclusion, specialty pharmacists are in a position to perform these clinical interventions that have a potential for significant cost avoidance for a health system. Using this information, it could create opportunities to help advocate for pharmacy service expansions into existing specialty care clinics. Because we know that the benefit from an HSSP and specialty pharmacist can lead to interventions and activities that could come as a great assistance to patients to help manage therapy and improve their specialty pharmacy experience, even if we don't have enough information to provide concrete associated cost avoidance. So pediatric HSSP pharmacists perform meaningful interventions that mitigated Medicaid-related issues, avoided associated costs, and improved quality of care for these pediatric patients. With the constant evolution of specialty pharmacy, so too does the role of pharmacists to ensure that drug therapies are accessible, safe, and effective. Thank you so much for listening to my presentation.